Ladies and gentlemen, now it's time to start with the webinar of the Diczfalusy Foundation, and I am really happy to learn that so many colleagues are interested in. The topics of this webinar is very interesting and very useful for the practicing gynecologist. And first of all, I want to say many thanks for the speakers. And the first speaker will be Roberta Venturella. And now I would like to introduce her briefly. She has a very nice and very rich curriculum vitae. At present, she is a professor at the Department of Experimental and Clinical Medicine, University Magna Carisia of Catanza, director of the Art Center at
Can you hear me? I'm not hearing anybody.
I hear you, Di Roberto. It might be that. Yes, now we hear you as well, Professor.
We hear you.
So I would like to repeat that at present she is a full-time professor of the Department of Experimental and Clinical Medicine, the University of Magna Graecia of Catanzaro. Her teaching activities is substantial. Among others, she is member of the board of professors at the PhD courses in molecular and translational oncology and innovative medical surgery technologies at the university. She participated in more than 100 national and international congresses and courses as a speaker. She is principal investigator in many studies. Professor Venturella's scientometric data also is remarkable. According to the Scopus total citation, 1,693, and her Hirsch index is 23. Today, she will deliver a lecture entitled Long-Term Medical Treatment Opportunities of Uterine Fibroids and Experiences with Relugolix Combination Therapy in the Clinical Practice. So, Roberta, the floor is open for you, and we are eager to listen your presentation.
Thank you very much for this nice and very deep presentation. I would also like to thank Gideon for inviting me, and also all of you for your participation to this very interesting webinar on the non-surgical alternatives for the management of such frequent pathologies that are uterine fibroids and endometriosis. I really think that it is important to be updated on the new medical options that are available in the clinical practice, also in a context of very expert surgeons, very expert in reproductive surgery, because all of you know that there is no surgery without risk, and that any surgery brings some consequences on the reproductive prognosis of our patients, and we know how much is appreciated by women to have more choice option. So focusing in the field of uterine fibroids, we know that up to 80% of women at age 50 will have to face with uterine fibroids. Although, fortunately, just 1/3 of them will be symptomatic, but data in the literature tell us that up to 50% of women will be treated by hysterectomy, this being one of the first indications in the world, with obviously consequent considerable social and economic cost. This is probably our responsibility. We should teach to our younger colleague that uterine fibroids become a pathology just when they are symptomatic or they decrease the quality of life of our patients. So how many women come to us and tell, they told me I have to subject to an hysterectomy, and we ask, but have you got any symptom? Have you have, for example, a disturbing bleeding or some pregnancy complication? Are you infertile? Or have you got any mass effect related to the presence of these fibroids? That could be, for example, urinary incontinence or pelvic pressure or constipation. So just in presence of this kind of symptoms, patients need to be treated. I also, yeah?
Roberta, we can't see your presentation.
Okay. So it was the second slide, so no much problem.
Thank you very much. Thank you.
So I was saying, just focusing on bleeding, I remember you that fibroids have been included in the FIGO classification of abnormal uterine bleeding, and particularly related to episode of EB menstrual bleeding, defined as excessive bleeding greater than 80 ml per cycle or prolonged cycle, able to interfere with social, emotional, and physical quality of life of our patients. Obviously, in this case, follow-up is not available as an option for our patients, and we need to find the right solution for that patient that can be medical or surgical. However, increasing data in the literature are now available, demonstrating that surgery is often the last choice for our patients, since most of them are really concerned about the invasiveness of the procedure and consider very important the uterine preserving options. Moreover, medical treatment reduces fibroids cost. As we can see in this study published in Canada, when ulipristal acetate was used, we remember that also ulipristal was not a very cheap drug, but it was still cheaper than surgery. And this is important in such the new scenario in which always less and less costs are available for our medical management of patients. So, which is the problem? The problem is that, unfortunately, the medical treatment option we have had so far are characterized by a number of disadvantages that still limit the use. Starting from progestin and progestogens are often used to manage heavy menstrual bleeding in women with fibroids, but they are not only ineffective, but also contraindicated, since we know that progesterone plays a fundamental role in the growth of uterine fibroids. So if we want to use this nice definition of Jacques Donnet in this recent review, using progestin in women with fibroids is like to add fuel to the fire. Also, levonorgestrel intrauterine device is an option that is chosen by a lot of gynecologists and is often really available and really efficacious in women with even menstrual bleeding. But high-quality studies are needed to evaluate these use in women with uterine fibroids, and up to now, the intrauterine device is not registered for this indication. And what about oral contraceptive? Off-label is also the use, in the management of uterine fibroids, but how many of us sometimes believe not to have any alternatives for our patients? On the opposite, you know, GnRH agonists are the fully registered drugs for indication, but they still have a lot of limitation. First of all, because they have a limited use over time, no more than 6 months due to hypoestrogenism, with the loss of bone mineral density and vasomotor symptoms. Moreover, the flare-up effect is often cause of more and more symptoms heavier than the symptoms that patients had before the injection. At the end, most of products are injectable and they need a very long recovery period after the end of treatment. That's why GnRH agonists are actually used in the management of the patient symptoms before uterine fibroids, because they reduce intraoperative, although they have no influence on the need of transfusion and only minor improvement in postoperative parameters. Up to few time ago, we had a disposition in Europe, ulipristal acetate, that was available and allowed the management of many women with uterine meiosis. Probably you know, authorities, due to few but significant episodes of acute life failure, have reviewed the prescribability of this drug. And today, its indication is more limited. UPA, indeed, is no longer an available drug for the medium long-term management of our patients. So, you know, there have been a lot of unmet needs in the medical management of our patients. Up to now, with a very minimally invasive drug with minimal side effect, but able to recover a good quality of life with a high patient satisfaction, and that was at the same time cost-effective and convenient. In this context, it's really important for us to have this new class of drug, GnRH antagonists, that is available for the management of uterine fibroids. Among them, relugolix, you know, it directly bind the GnRH receptor at the pituitary, and by these competitive binds, it prevents the presecretion of FSH and LH. As a consequence, limiting the production of FSH, there is a very important block in the production of estrogens. And moreover, the prevention of the LH surge inhibits ovulation, and therefore the corpus luteus does not develop, precluding the secretion of progesterone. So, in this context, GnRH antagonists have a lot of advantages of agonists. First of all, they have a very rapid ability of action. They have no flare-up effect. They can be orally administered, and they can be stopped at any moment with a very rapid recovery of ovulation for our patient. Relugolix, among the other, is actually available as a single dose, administration by the oral route, thanks to the dose-related reduction on estradiol circadian levels. Relugolix is now commercialized in a combination with milligram estradiol and 0.5 norethisternol acetate, and developed in a single oral tablet, single dose once a day, in order to maintain the estradiol levels within the physiological range of the early follicular phase of the menstrual cycles. You know that estradiol drives symptoms of uterine fibroids, but they are also essential for maintaining the bone health and for preventing some very annoying symptoms that are typical of menopause, such as hot flashes. The addition of low dose of progesterone was included to mitigate the unopposed estrogen action that could lead to endometrial hyperplasia. So, low dose of estradiol and progestin help offset the unopposed estrogen action and optimize estrogen levels to balance the potential benefit of relugolix, while maintaining bone health and minimizing side effects from the low estrogen state. So after this brief introduction, I'm now going to present the results of the Liberty clinical program, for which I had the pleasure to collaborate as a principal investigator in my site in the South Italy. In my unit at Catanzaro, we enrolled a lot of patients, and now I'm able to give you information about the efficacy and safety of relugolix combination therapy. So the Liberty program started from the Liberty 1 and 2 study. These were two replicated studies in which all eligible patients were randomized 1:1:1 to receive either placebo or relugolix combination therapy for 24 weeks, that are 6 months, or relugolix monotherapy for 12 weeks, followed by relugolix combination therapy for other 12 weeks. The Liberty 1 and 2 randomized trial was followed by the Liberty 3 long-term study, in which all eligible patients were submitted to relugolix in an open-label manner for other 28 weeks. So at the end of the Liberty 3, we had data about 1 year of treatment of our patients. Again, the relugolix Liberty 3 program was followed by the randomized withdrawal trial for all other 52 weeks of patients. So up to now, we have available data, and this data have been published just 1 week ago on the American Journal of Gynecological Obstetrics. We have data of patients that have been treated for 2 years with relugolix combination therapy. Starting from Liberty 1 and 2, patients could be enrolled if they were aged 18 to 50 with regular menstrual period. They have to have the uterine fibroid confirmed diagnosis by a centralized transvaginal ultrasound examination with at least 1 fibroid greater than 2 centimeters, or as multiple small fibroids with a very big uterine volume greater than 130 cubic centimeters. What was very important to be enrolled, patients have to have the menstrual blood loss volume of at least 160 ml during 1 cycle, or greater than 80 ml for 2 cycles, but it was assessed by the alkaline imaging method, that it was a very objective way to evaluate the blood loss of our patients. Obviously, patients couldn't be enrolled if they had to undergo gynecological surgery, or if they had any contraindication to treatment with low-dose estradiol or neurotestosterone acetate. The primary endpoint of the study, and it is very important, was the proportion of responders. Responders were defined as those patients with menstrual blood loss volume of less than 80 ml and at least a 50% reduction in the menstrual blood loss volume, again assessed by the alkaline imaging method. Obviously, the objective of the study was to evaluate the efficacy, but also the safety of relugolix that was administered for the first 6 months of treatment. Also, key secondary endpoints were evaluated. Among the other, for example, the percentage of patients with amenorrhea, the reduction, and it was probably the most important endpoints from our clinical point of view, that was the percentage change from baseline to week 24 in the MBL volume, but also the change in hemoglobin, the improvement in the value of hemoglobin in the so-called anemia evaluable population, but also the improvement in terms of pain, in terms of quality of life and other symptoms associated with uterine fibroids, and also the modifications in uterine fibroids and total uterine volume. Regarding the safety endpoint, obviously were collected also the treatment adverse events but also the change in bone mineral density, both at the lumbar spine and at the femoral neck and the total hip, and the incidence of vasomotor symptoms. As you can see from these baseline characteristics, they were well balanced between treatment group across the pooled Liberty population and very representative of the US population of women with uterine fibroids, with a mean age of 42, a very big proportion of Black and African American, a mean BMI above 31, an important MBL volume that was greater than 200 ml, and a very big uterus that was a volume above 40. I remember you that a normal uterine volume is less than 100 cubic centimeter. Going inside the result, the first I present is the principal endpoint of the study. In this slide, you can see the result both of the Liberty 1 and 2 and of Liberty 3. I remember you that in the Liberty 3, patients were all subjected to relugolix, but here data are presented by the parent study provenience in order to evaluate any difference between patients that were treated continuously for 1 year with relugolix by those that was providing for placebo or relugolix monotherapy. So, looking at the result at 6 months of treatment, as you can see, 75% of responders were observed in relugolix combination therapy, and this proportion increased at the end of first year of treatment, in which 87% of women respond to the definition of responders that I remember you was not only a menstrual blood loss volume of less than 80 ml, but they have also to reduce by at least 50% their MBL volume compared to the baseline. But what I say before, this is probably the most important aspects from a clinical point of view. This is the decrease in menstrual blood loss volume with relugolix combination therapy in the enrolled population. As you can see, a significant reduction in menstrual blood loss volume was observed with relugolix when compared to placebo at week 24, when 84% reduction compared to 19% in the placebo group. Moreover, what is really impressive, I think, is that a significantly greater reduction in menstrual blood loss volume was observed already in the first menstrual cycle with relugolix combination therapy, and at week 8, a close to maximum reduction was observed, and it was maintained up to 6 months of treatment. When we see the data at 1 year of treatment, as you can see, patients that continued the therapy with relugolix combination therapy achieved a 90% reduction in heavy menstrual blood volume at week 52. And again, patients that were randomized to placebo and then started to assume the new drug, the relugolix combination therapy, had a significant decrease in menstrual blood loss volume after 1 to 2 weeks of assumption of the drug. So this is probably the most significant effect of the drug we have observed in this study. What is also interesting is that the reduction in menstrual bleeding was not influenced by the location of the fibroid. So you can see that there was a significant reduction in the menstrual blood loss volume, both in people with subserous myomas, but also in those with intramural and submucosal uterine fibroids. And again, this is a very important outcome from the clinical point of view. Obviously, the reduction in menstrual blood loss volume has, as a natural consequence, a significant improvement in the percentage of amenorrhea in our patients, in which, as you can see, at the end of 6 months of treatment, 50% of women subjected to relugolix were amenorrhoic, and at the end of 1 year of treatment, 70% of our patients had amenorrhea, confirming that the positive effect of the drug was sustained and was greater in those patients that were receiving the drug for a longer time. The second natural consequence was that the percentage of women with an hemoglobin increase of at least 2 grams from baseline to the end of the study was in the study population, in which almost 55% of patients had a 2-gram improvement in relugolix combination therapy value. And as you can see, this effect was continued throughout the second part of the study, and at the end of the 1 year of treatment, a lot of patients completely recovered their hemoglobin levels. Moreover, also the endpoint related to quality of life and discomfort were significantly improved in patients with relugolix combination therapy. And as you can see, also menstrual pain and non-menstrual pain had a significant reduction in population of patients treated with relugolix combination therapy. It was significantly greater than women treated by placebo. The last of the efficacy effects and efficacy endpoint of relugolix combination therapy was the evaluation of fibroids volume and uterine volume. And as you can see, there was a significant reduction in the total uterine volume and an important reduction also in the fibroids volume in patients treated. We obviously had some concern at the beginning of the study about the safety of the drug, but the association with a low-dose estradiol was able to maintain the bone mineral density at lumbar spine and the total hip, both at 6 months of treatment and again at 1 year of treatment. So relugolix combination therapy was safe also from the bone health point of view. Moreover, the drug was generally very well tolerated, with the hot flash was the most frequent collateral effect. But if you look inside the result, you can see the percentage of patients reporting of flash was significantly higher in those patients treated by relugolix monotherapy for the first 12 weeks, followed by relugolix combination therapy. Although in patients with relugolix combination therapy, the percentage of hot flash was absolutely similar to those obtained in patients subjected to placebo. So in general, the incidence of adverse events with relugolix combination therapy was comparable to those observed with placebo. As I stated before, it was very recent, 1 week ago, the publication of the result providing from the randomized withdrawal study. The objective, the primary endpoint of this study was to evaluate the ability to maintain the menstrual blood loss volume of less than 80 ml also to week 76. In this withdrawal study, patients were again randomized to receive placebo or relugolix combination therapy, but the fundamental difference between the first randomized study is that in the withdrawal study, patients that recover and heavy menstrual bleeding were able to come back and to have again the administration of relugolix combination therapy. Moreover, we had interest to evaluate the time to recurrence of any menstrual bleeding in those patients that were randomized to placebo, and also the percentage of patients achieving or maintaining amenorrhea at week 76 and at the end of treatment, so at week 104. From the safety point of view, obviously, it was very interesting for us to evaluate the bone mineral density and the prevalence of any adverse events after 2 years of drug administration. So what you can see from this slide is that 80% of women randomized to placebo relapses at a median time of 6 weeks after the stopping of treatment. On the contrary, patients that continue to use relugolix combination therapy have a very important maintenance of the efficacy of the drugs throughout the second year of administration. In those patients that received placebo and which the menstrual blood loss volume again was higher after 4 to 6 weeks, again the administration of relugolix combination therapy was able to significantly reduce the volume in 1 to 2 weeks of treatment, and again demonstrating the ability of the drug to recover a very important and very reduced menstrual blood loss volume in our patients. And the drug was really well tolerated. The percentage of hot flash was negligible, and no new adverse events were registered in patients submitted to the drug up to 2 years of treatment. Moreover, also the bone mineral density was preserved both at the lumbar spine and the total hip in women treated with relugolix combination therapy at the end of the treatment. It is important probably to underline also that the drug is able to inhibit ovulation, and it was evaluated in a subpopulation of patients in which the efficacy in terms of reduction of LH, FSH, estradiol, and progesterone was evaluated every 3 days in order to evaluate the effect of relugolix on ovulation. As you can see from this study, relugolix prevented ovulation in all patients that were studied from this point of view. And again, it is interesting to underline that all patients returned to ovulation within 36 days after treatment. So the mean time to ovulation was less than 1 month, again confirming that the effect of the drug is very fast to be recovered after the stop of the treatment itself. So, what we need to understand, probably from the clinical practice, we do need to understand in more attention the effect of bleeding on submucosal G0 and G1 fibroids. We also need to understand the effect of the drug on the endometrium during surgery. For example, can we can we speculate that the endometrium will be atrophic, as is for example, GnRH agonists? We don't know. This is one of the endpoints that were not obviously evaluated during the study, because patients were not to be subjected to surgery. So we will know this aspect in the clinical practice very soon. Moreover, we are curious to know the effect of the drugs on the surgical outcome, for example, on the fibrous texture or intraoperative bleeding, what we have to expect during surgery, during the enucleation of the fibroids in patients that have been treated with relugolix combination therapy. And least but not least, the effect of the drugs in those uterus in which fibroids coexist with adenomyosis or adenomyomas. We can speculate that the important reduction in terms of total uterine volume reduction in these patients is related to extraordinary positive effect that relugolix combination therapy has in patients with adenomyomas. We really believe in this. And also the SPIRIT study that have been ongoing and available with most important data on the efficacy are confirming this aspect that relugolix combination therapy is also effective in the management of women with endometriosis and adenomyosis. So To conclude, what we know up to now is that relugolix combination therapy seems to achieve very favorable control of symptoms while reducing secondary effects in patients affected by uterine fibroids. And for all these reasons, it could represent a potential long-term treatment for women with heavy menstrual bleeding associated with uterine fibroids, and we was waiting for in the clinical practice, since a lot of women wish to retain the user, and the positive effect of medical alternatives to hysterectomy are really known. So which kind of women could be probably the best candidate to use relugolix combination therapy? For example, those women with no longer reproductive desire, but age more than 45 years, in which relugolix combination therapy can be used to accompany, to bring these patients to the menopause in order to achieve the best solution, that is menopause, avoiding any useless surgery. But also those patients in which we need to treat anemia and reduce the uterine fibroid volumes before surgery. And why not those young women with reproductive desire, in which, for example, relugolix combination therapy could help us to treat symptoms and preserve myometrium, also improving uterine cavity without the need of surgery. It was my last slide, and I am open to any question, curiosity, or any kind of doubt. And I really thank you again for your attention and for your participation.
Thank you, Professor Venturella. It was really a nice overview of the present problem of the uterine myomas. And I think your presentation generated a lot of questions. And now your paper is open for discussion. I kindly ask the audience, do you have any question? Please do not hesitate to ask Professor Venturella.
Can I intervene?
Yeah, please.
Yes. Hello, everybody. I'm Peter Kitulea, and I want to congratulate Professor Venturella. It's a very comprehensive and very interesting paper. But because I was doing from more than 40 years gynecological surgery, I can tell you something. My approach is the same. If the surgery is the last option, it's absolutely the last option, but sometimes you must operate. But I have a question about what's the difference between your product and the ESMIA, because I personally have very good results with ESMIA, and I have even patients with quite a large fibroids, which after 2 sequences of ESMIA to twice 3 months, it was disappeared. She has now almost a normal uterus. So I'm very pleased about ESMIA. What do you think about this?
Thank you, Peter. I totally agree with you. We, all of us, love the ESMIA. We have the very important results in women with uterine myomas with ulipristal yet, but unfortunately, we do not have the opportunity to use them in the long term of our management of our patients due to authorities' alert and due to the impossibility to prescribe. Moreover, I do think that GnRH antagonists in the combination with estradiol and progestin could have some improvement compared to ESMIA. First of all, because they have no negative effect on the endometrium of our patients. And moreover, because, as you know, a lot of patients had endometriosis or adenomyosis associated with uterine fibroids. With ESMIA, we had some very important collateral effect on the myometrium, on the endometrium, ectopic endometrium of these patients, And this is not observed with GnRH antagonists, because with GnRH antagonists, the positive effect in terms of reduction of the pathologies is again is at the same time on the uterine fibroids and on the adenomyosis. So if we could have ESMIA available, probably the two types of drug will work together and in different kind of population. I totally agree with you that ESMIA was a very important alternative for our clinical practice. But unfortunately, it is now not available for the long term, and probably relugolix can be the alternatives in the medium long term management of our patients.
Okay, thank you. Thank you. I agree.
You're welcome.
Thank you.
Thank you very much. Any other question?
May I have a question, please?
Yes, please.
My name is Bahadur Kurbanov. I'm from Uzbekistan. Greetings for everybody. Dear Professor Venturella, thank you so much for excellent presentation. It was really nice. The relugolix is a new product, and we are looking forward to work with this. Thank you so much. And as I'm also a young surgeon, I would like to give you one question, please. After the procedure, conservative myomectomy, or after the procedure hysteroscopy, when we illuminated the submucous fibroids, how long you recommend to use this product? For example, when we used ESMIA, sometimes we use for 1 year or from 6 months to 9 months as combined therapy, and we also had a nice results. But the relugolix, how long you exactly recommend to use it? Thank you.
Thank you for this really interesting question. The good news is that we know we don't have any limit to the use of relugolix, because data about efficacy and safety have been published up to 2 years, and usually drugs are not followed up to more than 2 years. So you can evaluate the situation of these particular patients in order to choose the time in which you have to stop the treatment. Up to now, you could also use it for 2 to 3 to 4 to 5 years, depending on what is your goal for that patient. If you want to bring them to the menopause after, for example, the myomectomy, resectoscopic myomectomy, you could. Actually, you could, because no adverse events in terms of liver function, and, for example, in terms of also bone mineral density has been registered. So up to now, you can choose your best duration of therapy for that patients.
So there is no limit. So there is no limitations. Yes.
Yes.
No
yes. No limits in the prescribability. Yes, I confirm.
Thank you so much.
You're welcome.
Thank you very much. And any other question? Would you be so kind as to tell us something about the contraindication? There is any contraindication to use this drug, or it's absolutely free?
Yes, the contraindication are comparable to those related to thromboembolism, for example, and the same contraindication that are for oral contraceptives. For example, a problem with the liver function before the therapy, or a bone mineral density that was already diminished before therapy. No other contraindication.
Thank you. My other question, do you know any limitation in the size of the uterine fibroid in which the drug is not recommended?
No, there is no limitation in the dimension, and I was very impressed when at the results, because again, remember you that in the study probably there were patients that were very very hard to manage. Probably in the clinical practice, we will have patients more easily to manage because that patients had a very big uterus, more than 400 cubic centimeters. So the drug was effective also in this kind of patients with a very important menstrual blood loss volume. I remember that to be enrolled, patients had to be a menstrual blood loss volume that was double compared to the definition of heavy menstrual bleeding. So I really attend the use of this drug in the clinical practice, and I think that it can be very helpful for us in the clinical management of patients that are affected by fibroids with symptoms that not have to be so heavy and so important as that we enrolled in the study.
Please.
Questions, Yuri. I think the most important contraindication should be if the doctor has the slightest hunch that it could be a process of sarcomatization. If we have a uterine fibroid which is starting to grow fast, you should operate immediately, because you never know if a sarcoma, for instance.
Yeah, totally agree.
I think this is the major contraindication in any conservative or minimal invasive approach. In any.
Yeah, totally agree, Peter.
Thank you.
Professor Venturella, do you have any experience using Relugolix before the assisted reproductive techniques?
Not yet, because in Italy the drug has been commercialized since 6 months, but just now it can be prescribed without any cost for the patients. At the end of September, we will have the opportunity to prescribe it because, in absence of cost. So we are already collecting patients that are interested, that have indications, but no direct experience up to now.
And if you see the international literature, what can we learn from this?
Again, we have no data available in patients with reproductive desire, because up to now the literature is about patients with no reproductive desire could be enrolled in the study. We have to wait and to read and to live our clinical experience.
Thank you very much. Any other question?
A short comment. By the way, Roberta, I am in Italy. I'm in Perugia. So we brought our daughter to the University of Perugia with the Erasmus. So I'm in Perugia. So you have a beautiful country.
Thank you so much.
Thank you. So,
I have a quick question.
Peter, please.
Yes, thank you very much for the lecture. And just the assisted reproduction came up. My question is, what happens to the fibroids when you discontinue the treatment? Do they regrow? How fast do they regrow? Because prior to fertility treatment, you want the fibroids to shrink or not to be there. But if they come back during the treatment or in early pregnancy, you are probably not helping the patient.
Yeah. Thank you, Peter. Up to now, data on the regrowth are not available, but what is probably to be considered is that this kind of preparation should be used just before the start of the reproductive desire, as we do, for example, with endometriosis. We do suggest to use this drug and immediately after the stop of the drug to try to get pregnancy by natural choice or by IVF.
I don't hear you, Yuri. I don't hear you.
Oh, yeah. So I would like to say many thanks again, Professor Venturella, for your excellent presentation, and it was very stimulating. And as you can see from the questions, you know, it was the take-home message was really good, and we learned a lot. And thank you again. And now we would like to proceed to our second presentation. And I just would like to know, yes, I see Sylvia, Sylvia Meschner. I am happy to see you. And now my duty to briefly introduce you. And Professor Sylvia Meschner is a consultant at the Department of Gynecological Charité University Medicine in Berlin, Germany. She is the head of the endometriosis unit with expertise in the clinical and surgical management of endometriosis. She leads the endometriosis research unit since 2005. Her research focuses on the investigation of pathogenetic mechanism of pain, including inflammation, neuroimmunomodulation, smooth muscle metaplasia, and invasion factors in endometriosis. Today, she will deliver a lecture entitled "The Role of the Medical Treatment in the Management of Endometriosis from the Clinical Point of View." Sylvia, the floor is open for you.
Thank you so much for the kind introduction. It's a pleasure for me to give a speech about the medical therapy and management of endometriosis. I hope everybody can see my screen. Okay, so endometriosis is a painful condition. We have problems with infertility, we have problems with pregnancy complications, and sometimes also malignant transformation. So it's a very challenging disease. For the treatment, we can work with surgeries or medical treatments, but the medical treatment, hormones and painkillers are working only in case of pain. They are not sensible for the improvement of infertility problems. With the surgery, we can improve pain and maybe also sometimes some infertility problems. The problem with endometriosis is that so long everybody was thinking that pain is normal, painful bleeding is normal, and that is the reason for the long delay until diagnosis has to be confirmed. Another problem is that diagnosis, for a clear diagnosis, we need a histological confirmation, and that is only possible by laparoscopy. So often in this situation, inconsequent surgical therapies were done, and that means there's only a short improvement of symptoms. Also, no long-term treatments were initiated, and patients suffer from recurrent pain, and then recurrent surgeries were done. And that is the normal history of a patient with endometriosis. Recurrent surgical procedures, no complete excision, no improvement of the pain in the long term, and finally, family planning often not regarded in the concept of the treatment. So many patients started seeking pregnancy at the age of 35, and then they have some difficulties because of recurrent surgeries also on the ovaries. That is a big problem, and we have this situation, not in this situation, of course, in many cases, surgeries and medical treatment is helpful for a patient with endometriosis, but in other situations, they develop pain under hormonal treatment, or they can't use hormonal treatment because of side effects, or due to seeking pregnancy, they are also unable to take hormones. So we have a big part of patients with ongoing pelvic pain situation. We looked for this. We did this pain profile in our outpatient clinic, and we saw that more than 90% of our patients with treated endometriosis suffer from ongoing pain. As you can see here, we investigated around over 200 patients, and 50% of them were with hormonal treatment, but they suffer also from cyclical and acyclical pain. That means they have also spotting under hormonal treatment. That means more cyclical pain, but the other part of the patients without hormonal treatment suffer also from acyclical pain and more often from cyclical pain because they have the normal menstrual bleeding. That is a big problem because here we have a group of patients with diagnosed endometriosis, but they suffer from ongoing pain in 90% of these patients, and the mean pain level was 6. That is very severe pain. So in order to find solutions, we need to understand the problem. And for this, it's very important to understand the pain mechanisms. At the beginning, we have a release of pain mediators from the lesions, but we need also an activation of silent nerve fibers. Both together means the peripheral sensitization. But on the other hand, there is also modulation on the level of the spinal cord, and finally, the pain permission in the brain. That means the central sensitization. It's very important to understand these mechanisms because disturbances were possible on all 4 levels. Yeah, we have a complex pathophysiology of pain in endometriosis, and yeah, when you see a patient, you need to think, has this patient active lesions? Is there the adenomyosis? Is neurogenic inflammation active? Or is there a problem with the muscle contractions of the pelvic floor, like a pelvic floor hypertension? Or is there a central sensitization present with a lower pain threshold? This is also very important, and that is often in patients with chronic pelvic pain, painful bladder syndrome, painful bowel syndrome, or vulvodynia. I think the main problem in the central sensitization development of patients with endometriosis is a long duration of pain, because they started with a primary dysmenorrhea over many years, and this information is going to the spinal cord over many years, and finally the modulation changed on the level of the spinal cord. There's a release of other neurotransmitters, and that these neurotransmitters leads to an expansion of the nociceptive field, and then patients suffer also from painful dysuria or defecation. Another problem is the pelvic floor hypercontractility, leading also often to hypertension of the muscles, and that is also a focus of chronic pelvic pain syndrome, and also dyspareunia is present in these patients. We focused our research on the understanding also what is a pathogenesis in the peritoneal lesions. So I'm sorry, because now I have not the animation modus, not the presentation modus, and you can't see the single pictures here, but I try to explain that these lesions, that we try to understand the reason for the pain, and there's a release of pain mediators and inflammatory mediators and growth factors and estrogen, of course. So we have also a strong inflammation present in this tissue with chemotaxis of immune cells. We have also neurogenesis in this tissue, angiogenesis, lymph angiogenesis, and also smooth muscle metaplasia and fibrosis. So there are a lot of reasons causing pain in peritoneal endometriotic lesions. At the beginning, in the most cases, the pain there is a cyclical pattern of the pain, but sometimes patients develop also pain under hormonal treatment, or non-steroidal antiphlogistics are not usable or not working anymore. What's going on in this situation? I think in this situation we have another topic of changes. Here we have an outgrowth of sensory nerve fibers with the release of sensory neurotransmitters. And sensory neurotransmitters are also a trigger for chemotaxis of immune cells, and they are a focus and a trigger for inflammation. On the other hand, we have a deletion of sympathetic nerve fibers, and the neurotransmitters of the sympathetic nerve fibers, the noradrenaline and adrenaline, are more anti-inflammatory. And so there is a disbalance of more pro-inflammatory sensory neurotransmitter to the more anti-inflammatory sympathetic neurotransmitters. And that causes the fact that there's a neurogenic inflammation present, and that might be the reason that the pain shift from a more cyclical pattern to a more acyclical pattern and a chronic pelvic pain situation. So as more nociceptive the pain is, we can work with hormonal treatment and surgeries, because there's a release of the estrogen-dependent release of pain mediators and so on. But as more nociplastic changes are present in the patients, we need more and more multimodal treatment options. We need painkillers, but also physiotherapy, osteopathy, for example, changes of the nutrition, psychotherapy, or complex pain management in these patients. So what is available for the medical treatment? We have the progestogens, the progestogen-only therapy. We have also combined oral contraceptions, and we have the hormone-releasing devices. That are the more first-line treatments. And for the second-line treatment, we have the GnRH analogs. That is an injection, and for this we need additional add-back hormonal replacement treatment. New are the GnRH antagonists. They are available as a tablet, and Elagolix is available only in US. But here in Europe, we are waiting for Relugolix CT. That is approved now in European, and we are waiting also the validation in Germany very soon. There are a couple of phase 2 studies, but most of them were cancelled, and they are working on non-hormonal treatment options. But for example, the P2X3 inhibitor, the last one, had a problem with liver enzyme elevation, and the study were cancelled. The P2X3 inhibitor is a blocker on endometriosis associated nerve fibers, and was an inhibitor for the neurogenic inflammation. So a very promising molecule, but it is a shame that the study were cancelled because of the liver enzyme elevation. So at the moment, we have only hormonal treatments available with a new product, the Relugolix, the GnRH antagonist, in the near future. The most guidelines gives a recommendation to use combined oral contraceptions. They are worldwide present, they are cheap, and they are working. But in my opinion, and also the opinion of Kaspar et al., the progestogens are better first-line treatment options because they are estrogen-free, and we have no idea if what is the estrogen part doing in the combined oral contraceptions, because Chaperon et al. Saw that users of combined oral contraceptive have a higher incidence of severe endometriosis in the history. So we have no I don't think that it's a good option, and we have the other possibility to use the progestogenes as first-line therapy. So in Germany, it's a good situation because the Dynagest is eligible for the treatment of endometriosis-related symptoms. We don't need a histological confirmation, and there's no time restrictions. So Dynagest is available for the long-term use. We have also the options of combined oral contraceptions or other progestogenes, but here it's an off-label use, and the Dynagest is covered by the health insurance. We can give a prescription for the Dynagest, and that is very comfortable. But sometimes patients don't or develop side effects under the Dynagest, and in this case, of course, we can look.
I can hear you. I can't hear you.
Sylvia, we can't hear you, and we can see one of your previous slide, medical treatment symptomatic only. Could you proceed, and could you turn on the microphone?
Yes.
Now we can listen to you, but
yes, now it's.
Could you proceed your slides? Oh, it's okay.
I don't know what this microphone is doing by themselves. It's unmuted every 10 minutes.
The microphone now, it's okay.
Okay. Okay. You mean the slide? Yes? You mean the slide?
We can see the hormonal treatment slide.
Yeah. Okay.
Okay.
The hormonal treatment. We have the progestogenes, available progestogene only therapy or combined oral contraceptions. And we have the hormone releasing devices. That are the first line treatment options, I think. And we have second line treatment options that are the GnRH analogs with ADVEC therapy, of course, or the GnRH antagonists like elagolix, but that is only available in US. And we are waiting for the approval of the relugolix CT in Germany, but it's available in European now. And that is a really good new option because it's a tablet, an oral tablet, and it's a combination with a low doses hormonal replacement therapy, a little bit estrogen and NETA. So it's easy to use, and it's more effective because it has a higher potential to interact with the receptors than analogs. That is a promising new option for the treatment of endometriosis. For other compounds, we have at the moment nothing else is available. There were some studies done with non-hormonal treatment options. The last one was a P2X3 inhibitor, which is a blocker of the neurogenic inflammation, but unfortunately, patients developed a liver enzyme elevation, and the study has to stop. So that is a problem. At the moment, we have only the hormonal treatment options and nothing else. The guidelines of many societies recommend the use of oral contraception, but I think the use of progestogene as first-line therapy has some advantages because they are estrogen-free, there's a lower risk of thrombosis, and we don't know exactly what the estrogen part, what is the effect of the estrogen part in the oral contraceptions in the long-term development of endometriosis, because Chaperon saw that patients with the long-term use of oral contraceptions develop more severe endometriosis under this condition, under this treatment. So it makes sense to use progestogen-only pills as first-line treatment. And we are happy in Germany that Dynogest is eligible for the treatment of endometriosis, excuse me, related symptoms without time restriction. That is very important. You can use it over many years, and you don't need a histological confirmation. It's not acquired. You don't need to do a laparoscopy first. You can start with the Dynogest in case of symptoms suspected for endometriosis. Of course, you can, in case of side effects under Dynogest, you can choose also another compound, another combined oral contraception or other progestogens that is clear, but that is off-label use in Germany. In Germany, the health insurance is covering the costs of Dynogest. Finally, it depends on the side effect profile for the patients. Patients needs to have a good life quality, and that depends also on the hormonal treatment. But the main point is that they need to be bleeding free. In this case, we can see if it's working or not. The GnRH analogs or the antagonists are also effective, but second-line treatment options. So the most often situation is that the patient is coming with typical symptoms, dysmenorrhea, cyclical pelvic pain, dyspareunia, and maybe also painful defecation and urination, but there's no organ damage visible by ultrasound. So she suffers only from pain. What to do then? So my recommendation is to figure out if she is under a hormonal treatment. If no, we need to ask why. Because of infertility, then of course she can't take hormones because they're contraceptive. So then she needs a multimodal treatment, of course. But often, and we have a really ongoing discussion with patients, and I'm sure that is all over the world the same, that they don't want to take hormones because of personal reasons. So we need to talk about them, about that endometriosis is a severe disease, that it's an estrogen-dependent disease, that there is a progression risk and risk of chronification of the pain. That is a very important point, I think. And in my experience, most of the people, when they understand the disease, they change their mind and tried or started thinking about hormonal treatments, and often they started then with an hormonal treatment. Another point is to figure out if they decline the use of hormones because of severe side effects. That is a point that we need to look for alternatives. Patients under Dynogest not seldom develop depression or mood changes are the main problems. So patients try to avoid ongoing treatment. In this case, sometimes combined oral contraceptions could be better, or you can combine Dynogest also with a transdermal estrogen application, or you can give the Dynogest per vaginal modus, or you can switch to another progestogen, desogestrel, clomidinone, dufaston, neta, or you can switch to GnRH analogs or antagonists, or you can try a local hormonal treatment. There are many, many other options available. If a patient is using a hormonal treatment, then the most important question is the patient bleeding free? Is she complete bleeding free? Because when they have spotting or bleeding under hormones, then it's usual that they suffer also from pain. So if she's not bleeding free, then optimize the dosage or change the treatment. Try double intake of the progestogens, one in the morning, one in the evening. Or try combined oral contraceptions, or try progestogen plus transdermal estrogen, or. You can use all combinations you want. Or you can switch to GnRH analogs or antagonism, or you can switch to aromatase, or you can add aromatase inhibitors. If she's bleeding free, but she's, for example, under oral contraception, then switch to the progestogen only situation, because we know that there is a cumulative estrogen concentration in under the use of oral contraception, and that means that this small amount of estrogen could be also a trigger for the endometriotic lesion, and that could be the reason for pain. So delete the estrogen in the treatment. Try progestogen only treatments here. Like all these options are open, but the most effective one is a Dynagest, because it's more effective than, for example, desogestrel. You need more desogestrel to reach the same effect as with 2 milligram Dynagest. The idea here is that the downregulation needs to be effective. That means you need to check if the ovaries are downregulated. If the ovaries shows functional cysts with elevated, then there's also an elevated estrogen level over 50 picogram per milliliter, and that could be also a reason for painful bleeding. So try to reach the therapeutical amenorrhea with changes of the hormones or double intake, or go switch to another option, the second line treatment, the GnRH analogs or antagonism. It's an artificial menopause, and the analogs you need to give an additional hormonal replacement treatment. And here the regularity, there's a combination included hormonal replacement treatment. In some rare cases, you can it's needed that you go that you add also aromatase inhibitors. The concept of the hormonal treatment is a central downregulation. We have no ovulation, and without ovulation, we have no estrogen production in the ovary, and the endometrium is very thin, and that means also lesions are inactive. In my recommendation, it's very important to use hormones in a non-stop modus, that there is no bleeding. We don't need a withdrawal bleeding with hormones. It's absolutely okay to have the non-stop situation. In case of bleeding, then you can use a double intake for progestogen as long as the bleeding is present. Then the patient can go back to 1 per day, or they make a withdrawal bleeding after 7 days if the double intake is not working. Please pay attention on the functional signs in this case of bleeding. Really often you will find then functional signs, and then the estrogen level is elevated. They have an outgrowth of endometrium, and then they have the bleeding. That is a very simple procedure to check always if the hormonal treatment is sufficient. I have one case for you. This is a 26-year-old patient diagnosed with endometriosis. She underwent surgery, and she was in such a chronic pelvic pain situation. She came with a hydromorphone therapy daily, more threefold hydromorphone every day. She was unable to continue the education and had a sick note. We excluded recurrent disease, decided to optimize the hormonal treatment. She was under normal combined oral contraception, and under this she had irregular bleeding under this treatment. So we switched to Dynagest, but bleeding went on. Also GnRH analogs, bleeding went on. We offered the psychosomatic unit, and she came as inpatient, but they diagnosed depression and distress, but no other comorbidities. So we needed to go on with the hormonal treatment. We started GnRH plus Dynogest. Bleeding went on. We inserted levonorgestrel releasing device and Dynogest. Bleeding went on. And it was a nightmare, really a nightmare. And the estrogen levels were so high. And as you can see here, the ovaries showed nicely functional signs. And here functional cysts. So no matter that the estrogen was 700, too much. And I didn't know what to do. But finally, I gave also aromatase inhibitors as off-label use, and after 3 months, she was finally bleeding free. So she was under GnRH analogs, levonorgestrel releasing device, and aromatase inhibitors. And then the estrogen level decreased, and she was fine. Sometimes it's very, very tricky, and we need the bleeding-free situation. Otherwise, it's impossible what to do. And that is what I want to tell you here. This new study showed some data about the duration of treatment with Dynogest. It's a real-world setting, a prospective non-interventional study in 6 Asian countries done. The patients were over 18 and they had a surgical diagnosis of endometriosis with the presence of endometriosis-associated pain, and they had an initiating of Dynogest therapy, as you can see here, and there was a follow-up of their situation after 6 and 24 months. And as you can see here, there's an improvement, the improvement of their symptoms, a long-term improvement. Only a small part of the patients has no improvement, and yes, a part of the patients have no change. But that is typical in patients with endometriosis. The pain is the best situation here, and so it's safe to use Dynogest as long-term treatment. And in comparison to other compounds, here is the placebo. That is the situation with no effective rate, here the placebo, and the best option, or one good option, is also the levonorgestrel releasing device, and the effective rate of pain improvement. And the Dynogest is this here. It's here, as you can see here, is from the systemic progestogens, the most effective one. And as you can see here, also the recurrence rate of situation, the placebo has no effect on the recurrence situation. That is clear, and the most effective one is the Dynogest. They compared also some other progestogens, but with a lower potential of the Dynogest. So I think it's a good long-term treatment. It's safe, it's tolerable, it's good to use, the Dynogest. I have good experience with it, but in some cases, of course, patients suffer from depression and mood changes. Then we need to look for other options. That is clear. I want to tell or to speak a little bit about the management of endometriosis, because in Germany it's often a surgery done in this situation with cystectomy, and then we have the problem of a lower AMH level, and then a problem for the fertility situation later. And another point is that we have also, after surgical excision of the cyst, a high recurrence rate. And as younger a patient is, as higher is the risk of recurrence. Here they compared the situation observation only, or the use of GnRH analogs and oral contraceptions and with observation only, you see that patients suffer from new cysts in up to 40%, and that is it's then a bad situation. A recurrent endometrioma is a nightmare for the follicular reserve of the ovary. It's little bit lower, the risk of recurrence is little bit lower in the group of over 30 to 40, but it's also 20%, and only in patients over 40, it's nearly the same. So here you can do the surgery and nothing else. But in younger patients with endometrioma surgery, you need to start with a progression prophylaxis and recurrence prophylaxis in these patients. It's absolute mandatory to give this recommendation, because we all know that the surgeries make a big damage on the AMH level of these patients, and that is a big problem later on. If they don't want to seek pregnancy at this time, they are getting older 5 or more years after such an endometrium excision. And we have a good option to start with a conservative treatment in case we see endometriomas. This study was done with Dynogest, and as you can see here, they started the treatment. The size of the cyst were 7 millimeter. That is a big cyst, and they started with the Dynogest treatment, and there was a size reduction down to 30 millimeter. That is a good effect on the endometrioma. If there's a break of the treatment, then of course the cycle is coming back and the cyst is growing again. So don't interrupt the conservative treatment of endometrioma until the patients want to go to seek pregnancy or to go into the IVF or whatever. As long as there is no active trial to conceive, it's a strong recommendation to use hormonal treatment, the conservative hormonal treatment. And as you can see here, also after surgeries, it's a good option to start the Dynogest to avoid recurrent endometriomas on these ovaries. It's really important to give this recommendation. And also new study is showing that the Dynogest is more effective than the GnRH analogs in combination with oral contraceptions. As you can see here, yes, I think it's in the first half year, the GnRH analogs are very effective. But when you use the oral contraceptions and you use it in a cyclical manner, then you have also the risk of recurrent endometrioma. And the Dynogest is a non-stop treatment. And if the patient is bleeding free, you have a very effective stop of the cycle, a very effective down regulation of the ovary, function, and you have an really effective progression prophylaxis. That is very important. This study is also very interesting because most people are thinking that deep infiltrating lesions are it's impossible to treat deep infiltrating lesions with conservative management with hormones. There is a meaning that they are not sensitive for hormones, but that is not true. The Italians are working a lot with hormonal treatment and they like to use NETA. And in this group of patients with deep infiltrating lesions, they used NETA, but in case of ineffective pain improvement, they switched to Dynogest, and then they had another step of pain reduction in this situation. So that is the confirmation what I'm telling you before. Switch from one lower potent progestogen to the more potent Dynogest. Also this case, they started a treatment with Dynogest in case of bladder endometriosis, and yes, as you can see here, there was also a reduction of the size of this lesion after, I think the duration was 2 years. It takes time, but it's really effective, and you can avoid surgeries. You can avoid surgeries with this procedure. So as I told you, we have the situation of ongoing pelvic pain situation, chronification of the situation. And for this, you urgently need also to add pain medication in these patients. It's absolutely useful and logical to use non-steroidal antiphlogistic to reduce the release of prostaglandins, or also spasmolytics, also in combination, it's useful. And another point is the pelvic floor problem. We know that the patients suffer from a hypertonus of the pelvic floor muscles. The power is different, the endurance is different, the coordination and relaxing possibilities are damaged in these patients. We have often a disbalance of the pelvic floor situation, and for this we urgently need pelvic floor relaxing exercises, yin yoga. We have also a vaginal biofeedback device for relaxing exercises and electrostimulation of the pelvic floor muscles. Also osteopathy and manual treatment is helpful, or acupuncture. And another big problem of these patients are this called endobelly, the cyclic bloating abdomen, and that is sometimes the most dominant symptoms in patients with endometriosis. What is helpful for this situation? We have no clinical trials available, but one recommendation based on patient reports is to use a more anti-inflammatory diet, more vegan, no sugar, no gluten, high amount of green vegetables. You can try also probiotics or low levels of histamine in the food. Then the patients have a good symptom reduction. Another point is to add also anti-inflammatory substances such omega-3 unsaturated fatty acids, or vitamin D, or vitamin C and E and A, selenium, zinc, all the antioxidants. And that is also very helpful in these patients, because we need to keep in mind that the ongoing pain is very, very stressful for these patients. They have often mood changes and depression, and that makes the situation more and more complicated. So we need a multimodal personalized treatment concept in these patients. Of course, surgery, hormonal treatment are the key players in the treatment, but we need all these other complementary treatment options. We need to give the patients a good concept and to find a solution and an improvement of the situation. Because I'm hoping that tomorrow the situation is changed. We hopefully know that symptoms are not normal, that we can develop screening programs for an early diagnosis of endometriosis, that we can do the sonographic diagnosis and start with an endometrial treatment also without surgery. So we have a long time pain-free situation. Of course, sometimes also pain developed under hormonal treatment, that is clear. And then we need, of course, also a good planned surgery. But then we need to talk also about the patients about the family planning, maybe give the patient the hint that they should think about family in case of endometriosis a little bit earlier than the normal or than usual, because many patients in Germany are seeking pregnancy after 30. So that is a big problem, because that is not the best biological age for pregnancies. And in case of endometriosis, in case of damage of the ovarian reserve, they often have a problem later on. So, and after finishing of the family planning, they need also good options, long-term options for medical treatment to fight and to downregulate the endometriosis. Yes, I'm really, really sorry about the technical problems here with my presentation. I really hope that you enjoyed the talk also with this technical problems. And I want to close the talk with this slide. This is a dorsal root ganglia from chicken embryo. And what you are seeing here are the outgrowth nerve fibers, which are induced after incubation of this dorsal root ganglia with peritoneal fluid of patients with endometriosis. And now I'm open for question. I hope you are with me here and I don't lost all of the audience here.
Thank you very much, Professor Mechner. It was a nice presentation, and don't worry about the technical problem. I think it's frequently could happen, so don't worry about it. Your message was, at least for me, crystal clear, and as I can see from the audience, everyone follow your presentation, and now your paper is open for discussion. Any question, Peter?
Yes, can I? Professor Messner, it was very interesting, and it's an all-day fashioned topics. It's endometriosis. It's a long and unfinished story.
It's a hurricane coming over us.
A long drama. So.
Yeah.
I was doing treatment in endometriosis, and I have some small observation. One is the fact that I have in the last 20, 30 years, very good results with ongoing oral contraceptives. It was very effective. No menstruation, no endometriosis. Yes, it's so easy. Second, I had have some cases in which I had third or fourth degree endometriosis, and I have to do total hysterectomy with annexectomy because the pain and the sufferance of the patients was unbearable. So if nothing is working, I think that the last resource is the total hysterectomy with annexectomy. And all these cases which was hysterectomized, after that they are well, they are okay, no problem. So there are extreme situations because the quality of life it's very poor in this situation. Second, all these things about the diet and so and psychosomatics, they are very useful, but they are only little helps in the great battle, you see. So the main problem is to get the patient amenorrheic, and if it's not possible, you have to do the surgery. Second, I personally, when I was doing surgery in patients with fertility issues, I was very conservative because we know that in the endometriosis surgery, we cannot be exhaustive. We cannot cut out all the endometriosis. It's an illusion. And to preserve I think, this is my personal opinion, to be exhaustive, to cut out absolutely everything, it's an illusion in general. So I was doing conservative surgeries with excision of the lesions only and preserving as much as possible by from the ovaries. And I have had successful results with this.
Don't touch the ovaries.
Yes, as many as possible. As few as possible, you must touch it. So, so endometriosis, it's not starting now, and it's not the end of the endometriosis. So, but it's very interesting. Your presentation was very interesting and very useful for the practitioners. Thank you so much.
Thank you.
Thank you.
Thank you very much. Any other question or comment? You know, I have a couple of brief questions. One is, how can you explain that in the United States, comparing to Europe, they went in a different direction? Let's say in the United States, elagolix, and in Europe, the relugolix was chosen. There is any substantial difference between the mode of action or the effectiveness of the two compounds?
No, in my knowledge, it's really, really similar. I have no idea why the development of elagolix is only available in US and relugolix in Europe. I don't know. I really don't know. I know elagolix is very expensive in US. The costs are over, I think, around 1,000 euros. And this might be the reason that it's not, that the permission of this compound, that they prefer to use relugolix because it's not so expensive. But I have no idea because I was not involved in all these discussions.
You know, my other question, you know, at least I have an impression that in the past couple of years or decades, the number of patients suffering from endometriosis are increasing. Does it because of
what is increasing?
The endometriosis patient number of the endometriosis patient are increasing? Does it because of the better diagnostic procedure, or do you know any other reason which can explain?
No, I'm really think that it's due to the better awareness of the disease, better education of the physicians, and also the that Dynogest is now available and it's more cheaper than before.
Thank you. Any other question from the audience? For the time being, I have one more question. You know, what's your recommendation for a young patient, let's say between 20 and 30 years, who so far has no child and would like to be pregnant? Which is the optimal treatment? How long time will you treat? And what the chance after 2-3 years of treatment to be pregnant?
So she wanted to get pregnant now?
Yes.
Or yes.
Wanted.
Then she should try for 1 year. After 1 year of unsuccessful conception, then we recommend the surgery to look and to clean up the pelvis. Of course, conservative, no touching of the ovaries. In case of endometrioma, you need to look for the AMH level first and make then a decision together with the infertility clinic what to do. But we have good results with clean up of the pelvis with the removement of all peritoneal lesions. And then she can, it also depends on her age, but you said she's middle 20. The sperms, of course, should be controlled of her partner. But if everything is okay, then she can go on a couple of months until another year. But then she could go to the infertility clinic, and then they need to help her with treatment.
Can I intervene? I think the best option is in such a situation, surgery, and after that IVF is the best results. surgery and IVF.
Okay.
But you need to try a little bit.
Yeah. Okay.
You are
Any
wasting
question?
time.
Any
And,
question or comment? No? No more question, no more comment? In that case, I have to say many thanks, Professor Mechner, for your nice presentation, and I learned a lot, and it was a very nice overview of the problem of endometriosis. And thank you again for the audience. And I would like to draw your kind attention that in October will be the Diczfalusy Award lecture meeting, the 15th meeting, as early as 26, 27, and 28 of October in Novi Sad, Serbia. I would like to invite you. It will be an excellent, outstanding scientific program, and I hope that we will see you in Novi Sad. Thank you again. If there is no other question or comment, in that case, I have to say goodbye.
Goodbye. Good evening.
Bye.
Goodbye.